Tune in every Sunday at 6 to RadioActive on WVUM. Each week, guests will dive into discussions through a community psychology lens aimed specifically at addressing structural inequality and root causes of our complex social problems. With me, Natalie Kivel, a PhD student in community well-being. Tune in every Sunday at 6 p.m. Let's get critical on RadioActive WVUM 90.5 The Voice.
We're going to take a quick voyage over the cognitive history of the 20th century, because during that century, our minds have altered dramatically.
Coral Gables, Miami, WVUM.
Welcome to the new age, to the new age. Radioactive.
What's going on, everybody? This is Natalie Kivel, your host every week on RadioActive. And RadioActive is a space where once a week we come together with guests, listeners, and myself to have dialogue on our social world. Through a community psychology lens, basically weekly guests engage us in a dialogue about social change, challenge our assumptions, and start conversations that are aimed at provoking us to engage ourselves in conversations that help to broaden our understanding of how we do social change and do social justice work. This week on RadioActive, we have Dr. Lenny Jason, a professor in psychology at DePaul University, coming at us on the phone. I first heard Lenny speak at a community psychology conference a few years back in Miami, and he spoke about, a whole bunch of things, but he spoke about chronic fatigue syndrome, which is a topic that's close to my heart. So I've been keeping my ear to the ground to listen about updates on his work and see kind of where the work on chronic fatigue syndrome is going, which is a little different than what we tend to talk about on RadioActive. So we're going to make the connection for you and talk about it from the community psychology perspective. But basically, when he started talking about how there was work going on around this issue, I thought, how can we learn about how community psychology can engage with this, and what do we as the public need to know about things like things about what we can do around chronic fatigue syndrome. So basically, I would like to let Lenny introduce himself and tell us a little bit about how he came to do the work that he does. So Lenny, are you there?
I'm there.
All right.
Hello, Natalie.
Hello.
So glad to join you, your show, and all the kind of read the people that are listening. I got interested in this topic around kind of almost 25 years ago. And really, it is a chronic illness, but it's something that happens with a number of illnesses that are hard to define. So I think the same issues that go for this particular illness about kind of people feeling sort of marginalized and stigmatized and having lack of access to services could pertain to actually quite a few illnesses out there. So I think there is some generality. And the key question in this issue is really, how do we get people involved so that they become participants, so they become active? And I think that's what really kind of generalizes across illnesses. This particular illness, when I got involved in doing research with it, was something that was called kind of the yuppie flu. People were characterized as being, kind of very affluent white middle-class women. And in a sense, that was what was the typical thought of what people had. The individuals were thought to be probably kind of psychogenically determined. It was probably something thought to be something comparable to depression. And individuals were, in a sense, kind of given a name that was somewhat stigmatizing, chronic fatigue syndrome, given a case definition that was not really very good at identifying the people who really had this illness. And there were treatment approaches that probably were not kind of really appropriate for this illness. And again, there were so many issues involved in 25 years ago that it was, what happens when you have an illness where you don't have clear kind of markers, clear biological markers.
Yes.
And that was the situation that existed then. And a lot of people really doubted the authenticity of this illness. A lot of people really considered folks with this illness as individuals who were malingerers or people who, really had more of a psychiatric condition, probably some type of low-grade depression. So that's the situation that I was in when I looked at the literature, when I got interested in it many years ago. And certainly it was, a fascinating set of issues to deal with as a psychologist.
Excellent. Thank you. And it's interesting for me because part of the reason why I have this show is to both bring in different people who talk about social issues and come from the community psychology perspective, or to bring people on who don't know what community psychology is and, talk about what they're working on, and I frame it in a community psychology perspective. And so it's really interesting to me that anyone I've had on my show doesn't do work anything like what you do, yet we're all in the same field, right? And so either for new listeners who've never heard what community psychology is, or return listeners who maybe want to have an idea of the diversity of the field, could you tell us a little bit about what community psychology is to you and how you do community psychology?
Sure. Community psychology is really kind of like a public health approach. So in medicine, which most people are familiar with, there's physicians who treat people on a one-to-one basis when they have problems, and that would be like setting a broken arm. But there's public health people who really try to say, well, gee, how do we get out into the community and stop people from exactly maybe having automobile accidents, or try to get people to get into their seatbelts or things like that. So one's public health, one's systems, what's environmental, one's person-environment fit. The other one is more very individually focused. And in psychology, that's the difference in part between a clinical psychologist and a community psychologist, from it, like traditional medicine versus public health. I think the key issue that's different for me from a pure public health point of view, however, is that in our field, we very much want to be at the grassroots. We want to hear the people. We want to find out what they care about. We want to work with them in some capacity so that we can work to try to solve problems together. So that partnership, that in a sense, that connection with either patients or citizens or whatever the group is really a key feature of this illness. And again, just the last piece that I mentioned about community psych is that we want to understand people in context. We don't want to understand people outside of their context. And that's a critical thing. How does context and people, in a sense, kind of interact? So we always want to understand the surroundings and the environment. So, for example, a kid who's basically in one school system might do fine, but that same kid in another school system that's plagued with inadequate resources, gang violence, and low teacher interest in what they're doing might have very different outcome. So that's why we always want to understand the environment and the child, or the environment and the person, as we understand interventions.
Excellent. That was a very comprehensive definition. I think you've done this before. Okay, and the interesting thing for me is kind of setting the stage with the link between community psychology and your work on chronic fatigue syndrome. For me, it's interesting that in some ways, a lot of community psychology has moved away from traditionally engaging with medicine or psychology, and a lot of it's in some ways very separate from it, and that your work is still directly related to it, yet you're still doing it in such a different way than the traditional medical model, right? So can you talk to me about the links between why community psychology feels like a good fit for the work that you're doing with this disease?
Sure. Again, just to give you an example of kind of what happened in my field, in 1988, there was an illness that was called myalgic encephalomyelitis that was frequently diagnosed in some of the European countries. At that time, the Centers for Disease Control found an outbreak of this illness in Incline Village, Nevada, and they renamed the illness chronic fatigue syndrome. And they actually came up with a new case definition that was very different from the one that had been used by a person named Ramsey. So in a sense, you have a very elite, very powerful, very prestigious institution that takes a disease, that takes an illness, and renames it, and also gives it a new definition. And that's an interesting process from a community psychology point of view. Where were the patients? Where was the people who were affected by this? Did they have an involvement in the renaming of their illness? And they didn't. And so for the next, in a sense, 30 years, you have people who are extremely unhappy about this case definition and this name that has been imposed on them. So in medicine, we have to be very careful of what types of names we put on people, because if we put names on people that end up trivializing what they have, and if we create a case definition that doesn't identify the right people, that creates all types of problems for science and the patient's experience of stigma. So from a community psych point of view, I was very interested in understanding these processes and how patients were systematically denied access to the decision-making that really needs to be critical for this field or any field to really have legitimacy and to have buy-in by both patients, the physicians, the scientists, and government officials.
Okay, so it sounds to me like this is obviously an issue that's pervasive across diseases far beyond chronic fatigue syndrome. And so later in the show, we're going to talk about transformation and structure. But in your work, does this stand alone, or have there been partnerships with other patient groups, or is there like a movement around what patients are up to engage in their health?
So there isn't a day that goes by without me being contacted by patient representatives or patient groups.
Wow.
The patients are absolutely wanting to find allies within the social sciences or within community psychology for myself.
Okay.
So I have access to people who are interested in trying to think about what we can do to make this different. So it's really a fascinating situation. Myself as a scientist, I have connections with the scientific community almost on a daily basis as well, with, in a sense, the patient community almost on a daily basis, and also with government officials. So I have access to three audiences where I can play, in a sense, sort of a gatekeeper between them. And I can be dialoguing between them and trying to figure out what can be done to possibly improve communications between these different constituent groups. So for me, as a community psychologist, this is really a fascinating situation to be in and to try to understand what are the processes by which so many people have been left out of the decision-making process. It's fascinating from a psychological point of view.
Wow, sounds like they keep you very busy. And we're going to go to our first break in about a minute. So is there anything that you wanted to just leave us with to make sure that we have all the necessary information to kind of dive into why this is a big issue and some of the transformation stuff after the break?
So we estimate that something like maybe 1 million people have this illness in the U.S.
Wow.
And it costs society probably about $20 billion. So this isn't an inconsequential problem. And just also to mention that patients with this illness have problems that are severe as any other of the major chronic illnesses. Mm-hmm. And when you look at functional disabilities, actually people with this illness are more seriously impacted than anything else that you can think of.
Wow. All right. Well, thank you for setting the stage for us. We are going to go to our first break right now. You are listening to Dr. Lenny Jason on the phone down from Chicago, telling us about chronic fatigue syndrome and the current or most recent name change and what we can do about it in terms of patient engagement and engaging community psychology. You're listening to RadioActive on WVUM 90.5 The Voice. We will be right back after the short break. Keep it locked.
WVUM.
Best said by Marie Curie, who said that one never notices what has been done, but only what remains to be done.
Coral Gables, Miami.
So close.
Just imagine in a classroom,
WVUM.
a teacher writes on the blackboard and a blind student can see what's written and read using these non-visual interfaces.
Coral Gables, WVUM.
Welcome to the new age, to the new age. Radioactive.
Welcome back to Radioactive on WVUM 90.5 The Voice. This is Natalie Kivel, your host, and I have Dr. Lenny Jason on the phone with me, joining us from DePaul University in Chicago, talking about chronic fatigue syndrome and the connection that it has with the work in community psychology and how we in community psychology can engage with this kind of work. So if you have any questions or comments, please text in to 786-309-8861. And we are now going to dive into a little bit more about the history and development of our understanding and how something like chronic fatigue syndrome became legitimate in the eyes of the medical world in America. And so, Lenny, if you want to just continue on your conversation about the history and just give us more of a background as to how this came to be so well-known and so legitimate.
Sure. You know, the United States has to be very careful what it does because it's so powerful in its institutions. The Centers for Disease Control and Prevention basically says, here's the name of a disease or a syndrome or an illness. I mean, people from around the world listen. So the United States has to be careful not to be imperialistic. It needs to be careful that if other countries have come up with a name, they don't just come up with their own name and superimpose that on it. And that's actually what happened in 1988. And that process has continued. We'll talk about that later over the next 30 years. But when I got involved in research back in the late 1980s, early 1990s, the Centers for Disease Control, not only had they renamed the illness, but they did survey research, it's called epidemiology, where they're trying to estimate prevalence. That was very biased. So they went into 4 cities. They got the physicians in those cities to nominate their patients to sort of say, okay, who might have this illness? And they estimated prevalence based on that. Well, here's the problems with that type of study. A lot of physicians didn't believe this illness existed, so they wouldn't nominate their patients as being possible candidates. And a lot of patients don't have physicians because they're out of the healthcare system, because it's a different system that we have in this country that a lot of people aren't part of. So if you take that, you really got an underestimate. And they estimated that maybe less than 20,000 people in this country had the illness.
Wow.
But that was interesting because there was a patient self-help group that was almost that large. And also the Centers for Disease Control was getting almost 4,000 phone calls a month from people saying they had problems with severe fatigue.
Wow.
So again, if you listen, if you hear what people are saying and it doesn't match what the research suggests, that's a good reason to challenge the research. And patient groups were working at that time to say, can we get counter information? And that's what the community psychologist does. Is it possible to get counter information to break stigma, to break myths? And that big myth was that this was a yuppie flu disease that was very rare and primarily affected white middle-class women. So we eventually got funding, working with different organizations and citizen groups, and we did a community-based study where we contacted thousands of people by telephone, and then we brought in those people who had some of the symptoms, and our estimate suggested that rather than 20,000 people, actually it was close to 1 million people had this illness.
Wow.
So that became a kind of game changer, when in a sense an illness goes from being extremely rare and very kind of biased group to a disease that basically affects not only hundreds of thousands of people, but most of the people it affects had never been diagnosed. So that suggests we have a major public health problem. So doing that type of focused research, if you can believe it, took almost 10 years.
Wow.
So one of the characteristics of community psychology is you have to be willing to hang in there, be committed to something, passionate about it, stick with it long enough to make a difference. And when that research came out, and ultimately the Centers for Disease Control did some similar type research with community-based surveys, found somewhat similar results, and we basically were able to change the game. So in other words, if everyone thinks an illness is very rare, it's going to have very little influence in terms of getting public resources or recognition. So one of the things that we worked on first was, let's get the prevalence piece right. And we worked on that, and that's what our first step in this area was.
Okay. We actually have a question from a listener that goes well with this current aspect of the conversation. In your experience, or in the experience of the patients, do you find that there's a differential diagnosis across class lines or across different groups? So I'm assuming what the listener means is this idea that if you're outside of the healthcare system or you don't have a primary physician, is this something that's kind of being lost on a whole population that's suffering?
Yeah, 90% of people are not diagnosed. So there's a lot of people who are sick and that are ill that haven't gotten an appropriate diagnosis. And the other interesting thing is, rather than a yuppie flu disease, we actually found that it occurs more often in people of color, people of lower socioeconomic status. So it's not just the wealthy yuppie people that get this illness, which is a myth. And shattering myths and shattering these types of stereotypes is one of the functions of community psychologists. When we see something that's not right, we can work with others, collaborations, research, to basically try to find out what the truth is.
Excellent. All right. And one of the things that came up for me when we were planning this show is that when something happens in medicine, and this is why it's so outside of my realm of knowledge in terms of what I study in community psychology, is like, we see doctors as experts, they know things. And so why is it so important that this conversation is happening around patient engagement? Why, I'll just let you start there.
So in a sense, physicians have a tremendous amount of training, and their usual style is to basically diagnose and then treat. Yeah. And they basically have very little time to make a diagnosis, and they offer some type of treatment. But the dialogue is not there often. So patients, if you ask them what's the most important reasons they come to a physician, they actually don't discuss those things in the 10 minutes or so that they have with their physician. Yeah. So if you look at a list of things that in terms of why patients go to a physician, actually things like fatigue and pain are really at the top of the list. But if you ask physicians what's most important, they basically put things like fatigue and pain at the bottom of the list. So in a sense, there's a mismatch that occurs. Okay. So the role of community psychologists is to find their voice and to give their voice expression in the research, in the policy, and the types of programs that can occur. And unless we basically get the patients involved actively, then there's a very large player that's not at the table and not part of the process of transformative change.
Excellent. Well, and also, I mean, in my experience of understanding participatory research or action research, there's also benefits to all involved, right? So can you speak to not only that it's helping to articulate their experience or articulate, what patients want this to be called, but also are there other benefits to just being engaged in your own health and your own life?
That's right. I talk to patients frequently who call me because there's not a lot of health care. There's not a lot of programs for people who are around the country. So, for example, if you had MS, if you had cancer, if you had a number of illnesses, you can go to a treatment setting that specializes in that. In this area, there's very few of them, and it's very unfortunate. So we really need centers of clinical excellence, and we don't have them now, and that's very unfortunate. And that's one of the things that patients are asking for, so that they can go places. But when I talk to patients who often don't have this, what I say to them is they, in a sense, have to put together the best treatment team possible, because they can't go to a center for clinical excellence. So they have to aggressively go out and find what's available, look at the literature, interview physicians, try to find the best one in their area, and put together a team. It might be someone that kind of works on pain. It might be someone that works on immunology. It might be someone who works on rheumatology. This illness affects all the different systems in a person's body, so they can't just have one person working with them. They might need a nutritionist to deal with kind of food allergies. They might have mold that's influencing them, so they might need an environmental person to work with them. All these different fields have to come together. Because we don't have centers of clinical excellence, it's incumbent upon the patient to try to put this together. A very difficult task, but I do think those people who put together the best team have the best chances of doing better with this illness.
And in terms of having to go out and create your own team, so another question from a listener, they're just coming in tonight, is that if doctors have so much power, and so I've had an experience with a doctor that said something about, chronic fatigue syndrome was invented after I went to med school, so I don't know anything about it. And, the word invented was this very interesting term to use in that conversation. And so are there other groups that, and it sounds like patient engagement groups potentially is what the answer might be, but are there other groups that are kind of mitigating how legitimate this is to get beyond individual doctors who may or may not believe in it?
That's right. So in a sense, if you have lots of physicians who are skeptical, then we need to have those counteragents. There is something called the International Association of MECFS that basically is a scientific organization, and they recently put a primer out that's excellent information that basically can be used for both patients as well as to educate physicians. That's available on the website of IAA, International Association of MECFS, so that they can find that and they can get a hold of that primer, and that can be used to kind of educate. But there's other groups that are out there trying to make a difference. Patients are out there creating polls. Other patients are out there creating resources. Other patients are out there kind of creating opportunities for funding. There's a tremendous amount of activity that's happening where patients are taking charge to try to make a difference. There's patients who are putting together ACT UP like interventions where they're basically trying to, in a sense, rally support for change. There's so much excitement going on in this field. Truthfully, it's almost like the HIV/AIDS field of the early 1980s. A very exciting time to kind of see all these forces coalescing, synthesizing, and the agitation for change is palpable.
Excellent. Okay, and so just before we go to our second break, is there anything else that you want to say on the historical context or on the reason why this is such a big issue? And then we'll dive into some more structural stuff after the break.
This is a critical issue because you have hundreds of thousands of people who are denied access to care, who basically are not able to get their basic needs met. And the situation not only is tragic in this country, but around the world.
Excellent. Oh, thank you so much. Okay, so we're going to go to our second break, and we will be back in just a minute. But if you have any questions or comments for Lenny or myself, please text into 786-309-8861. We are on air tonight talking about chronic fatigue syndrome, patient engagement, and the role of community psychology. You're listening to Radioactive on WVUM 90.5 The Voice. We'll be right back after the short break. Keep it locked.
WVUM.
So my name is Taylor Wilson. You may ask me, well, how do you know what our energy future is? Well, I built a fusion reactor when I was 14 years old. I developed a detector that replaces the current detectors that Homeland Security has.
Coral Gables, Miami.
To celebrate, fool around, meet me right next to the counter, and I found a quiet place. And please come down and tolerate now. Hit the ground, is that a way to celebrate? Move around, I can't stand that sticky space. I found a quiet place, and please come down and tolerate now. I'm still falling for this fiction. These legs are too long to fit my screen. Hit the ground, is that a way to celebrate? Fool around, meet me right next to the counter, and I found the quiet place. And please come down and tolerate now. Hit the ground, is that a way to celebrate? Move around, I can't stand that sticky space. I found the quiet place, and please come down and tolerate now. I'm still falling for this fiction. These legs are too long to fit my screen.
WVUM.
There is an ancient proverb that says it's very difficult to find a black cat in a dark room, especially when there is no cat.
Coral Gables, Miami. WVUM.
Welcome to the new age, to the new age. Radioactive.
Welcome back to Radioactive on WVUM 90.5 The Voice. I have Dr. Lenny Jason joining us on the phone from Chicago, from DePaul University, and we're talking about chronic fatigue syndrome, the role of community psychology, and issues around patient engagement. So if you have any questions or comments for us, please text into 786-309-8861. And to start this next section, we're going to have Lenny tell us about the more recent name change that happened around chronic fatigue syndrome. So can you just tell us what's been going on more recently with this disease?
Sure. As I mentioned, kind of, it's a long history. So really briefly, in 1988, the Centers for Disease Control and Prevention came up with a new name called chronic fatigue syndrome and replaced myalgic encephalomyelitis, which the illness had been known for before. So in a sense, around the world, the CDC in the U.S. took a new name and it went around the world. And patients have, for the last, in a sense, 25, 30 years, been very upset about this name. Chronic fatigue syndrome, because in a sense it says chronic fatigue, but everybody experiences fatigue. So if you had if you had a cough and you said chronic cough syndrome, you'd say who cares? But if you say it's something like emphysema, then all of a sudden you say this means something. And we've actually done research that suggests that names do make a difference in attributions. In any event, go forward to today, and the Institute of Medicine, which is a very prestigious group of individuals who are brought in from the outside to set kind of reports, recommendations, has just issued their report about a week ago. And they have called for a renaming of chronic fatigue syndrome to something called SEID, Systemic Exertion Intolerance Disease. Now, this new name also has a new case definition. Let's just talk about the name for now.
Okay.
SEID is a name that, again, a group of people has come up with and imposed on the U.S. and ultimately imposed around the world. And you've got this uprising because in 1988, you didn't have the internet. In 1988, you didn't have the organizations. You didn't have the people who were trying to say, we're not going to allow this to happen. Well, today, it's a different situation. You've got some people who feel, well, it's better than chronic fatigue syndrome, so let's use it. But it's unclear how many people feel it's different. And is it really helpful? And there's actually many, many voices that are coming out that are saying, we don't want this name. But it's not just the name, it's the process. We're patients involved in coming up with a name that affects them. And that's the case. If they're not involved, they're going to be less likely to accept it. And that's the community psychology point of view. How do we get people's voices? How do we get their opinions? How do we get their involvement? And that's what we're about in this field, is to basically give voice to people who basically have been excluded from the decision-making process.
Yes, exactly. And you mentioned in the IOM report that it's a recommendation. So does that mean, what does that mean in terms of actual decisions?
So they make a recommendation, and other groups then take that recommendation. And if you have people like, for example, the Chronic Fatigue Syndrome Advisory Committee, which is a government body that makes recommendations to Health and Human Services Secretary. So if they basically take this recommendation and say, we want the name changed, that will have more influence. So yes, if groups rally around their recommendations, that those recommendations end up becoming policy.
Okay.
If groups don't rally around those recommendations, it's less likely that they'll have that ripple effect. So yes, right now we see a ground source of activity that's going on around the country. And again, it's really fascinating from a community psychology point of view, how we can get patients more actively involved in creatively being involved in their future in terms of what is meaningful for them in their participation with this illness.
Well, and that leads me kind of perfectly into the next question, because when I was reading, you've written a lot of blogs on this. I went through a lot of what you've written on this because it is both timely because of this recommendation and just very interesting to see that we know all these things about participation and we know all these things about how we should be creating change, and we don't tend to actually do them in a lot of ways. And so your work is really trying to move the needle on that. And so in one of your blogs, you mentioned this idea of transformative change in terms of patient engagement. And that's a word that I've spent a lot of time kind of struggling with academically, trying to figure out what we actually mean by transformation. And so if right now is a time where organizing would make change, I mean, what does that look like in terms of your idea of transformative change for patient engagement?
Okay, so fascinating question. And to get into the situation where one can be dealing with transformative change, one has to have a historical perspective on that issue. One doesn't just parachute into a particular illness or situation or problem and be able to successfully make that transformative change. So in a sense, how does one get to know the key players? How does one get to be trusted by individuals? How does one, in a sense, participate with that community? So over time, if one stays committed to something, one builds up social capital. And that capital allows one to ultimately be in positions that one can ultimately influence things. So what I'm basically saying is get connected with the different key players, particularly patient groups in my case. And number two, stay, in a sense, a character that is viable, that has some type of worth to individuals so that they see you as helping out with their efforts to bring folks together as well as problem solve. So yes, I've been very active, and as a function of that, I ultimately get contacted constantly by people who say to me, I'm a patient, what can I do? I feel that we need to change. I represent an organization, I don't know what to do. So as a community psychologist, what an opportunity to dialogue with people who are trying to make some meaning out of this craziness that's going on, which often social change is about, with all the conflicting paradoxes that are occurring, and try to, in a sense, hear the voices. So yes, what I do is I encourage people, for example, to be concrete. There's one patient who basically said, you know, this is really something. They came up with a new name, and in a sense, we don't know, in a sense, whether people like it or not. So I said, well, gee, why don't you collect some information, develop a poll, and find out how people feel about this particular name? That poll went out today, okay?
Wonderful.
We expect that poll to have hundreds of people giving their experiences of what they think about the name. That information then becomes a critical player in the process, because now you're going to have patients who are ultimately going to be able to give their point of view to influence the different bodies that will ultimately come together to make the decisions. So when one tries to get patients involved, one has to think about the spaces that are important so that people can collaborate and make a difference. And to the extent that one can articulate those processes clearly, you have a better opportunity to actually see those changes enacted.
So as you've been in this field working with these patients for a long time, and so you get the poll's happening this week, and you're going to hear a lot more information. But I can guarantee you, there's already probably a lot of information in your head in terms of how patients are thinking in this moment. And so we have another question from a listener that's wondering if this is how patients want their time spent in terms of focusing on the name rather than the cure and treating the symptoms. And how do you see those things as kind of interrelated in terms of building up enough resources for this disease? And how are patients kind of speaking about those different things in terms of the name and the case definition, and then the money for cure and treatment?
Okay, so in a sense, if you want to be effective in the policy arena, one has to be focused like a laser on trying to accomplish some very specific tasks.
Okay.
And in this area, one can't do the hundreds of things that are necessary because they don't involve too many resources, and we don't have enough kind of personnel or money or funds to do all the things. So I would say if one were to think about a list, one list would have to be, in a sense, centers of clinical excellence, where a person could come in and actually get their illness diagnosed and treated. We don't have that now. That's got to be at the top of the list. Another issue has to do with funding. Right now, research in this area is funded about the lowest level of any illness or disease at NIH.
Wow.
So that has to be another issue of how do we get more funding? How do we get more grant applications sent in? How do we get more researchers to find out what's going on? So that's another area. A third and a fourth area are also important. How do we name this entity? How do we develop a consensus, not just in the U.S., but internationally? And that's where community psychology has such an active role, because we can be a player to set the process, not the outcome. We can talk about what does it mean to be transformative? What does it mean to basically be participatory? What types of structures need to occur to allow the greatest number of people to be involved in the decision-making process. And to the extent that we can think in those terms of process rather than outcomes, we have a better chance of bringing all the different key people in to be invested in a particular product, a name, or a case definition. And that's what's exciting, and that's something that we do have a very specific role to play in this illness.
Excellent. And you just touched on this idea of, people around the world. And when you're talking about the IOM, first of all, I'm interested in kind of who's on that committee that made these recommendations. But also, are there any processes of making this a global conversation? I mean, if we're talking about kind of American imperialism and changing the name and having other folks, I guess, in English-speaking countries adopting this, what does that look like if we ever wanted to make this a global conversation?
Yeah, there's matter of fact, today I was in touch with people from the Dutch Netherlands who are basically have a global ME journal, and they are basically trying to pull together people from around the world to, in a sense, get the voice out. So it's really a great organization.
Wow.
And they are, in a sense, actively involved in thinking about the name. And there are groups in different countries who have called themselves ME for myalgic encephalomyelitis. So they've renamed their organization, and they don't want their name taken away. And they're basically saying, who the hell is this in the U.S.?
Yeah.
Basically tell us what name we are, because we know who we are. So very interesting. Now, again, in public policy, one has to be very careful not to demonize individuals. People who are in the Institute of Medicine are very senior scientists. They're very bright people. They're very caring individuals. They're trying to do the best they can do. But that doesn't mean that what they're doing is what's in the best public interest. So I think we have to recognize that people can make their best effort, but if the process is exclusionary, if the process is not inclusionary, if the process is based on secrecy, then you're starting off behind the 8 ball before you even start this change process. And that's exactly what's happened in this area. And we, as community psychologists, can challenge those processes and talk about alternative ones that can actually correct the abuses of the past.
Wouldn't that be great? And that's interesting to think. So if there were more community psychologists or other action scientists of any kind, I guess, engaged in this, what would that look like? I mean, this sounds like it's way too big for any one person to tackle. What would this look like in your ideal world if community psychology rallied behind this issue or this kind of work, and we were able to accomplish all of the things that you want to accomplish? How would we do that?
So what community psychologists have to be willing to do is stay committed to an area for a long enough period of time. So, for example, we're good at crunching numbers, so we can help develop surveys. We can help develop polls. We can help develop studies to validate patients. There's hundreds of things that we can do, and rather than talking abstractions, let me talk about something very specific. A patient who was sick contacted me and basically said, everybody hates the term chronic fatigue syndrome. We need to demonstrate that it basically really has negative effects. I said, well, how do you do that? And she, who had been trained in social psychology, said, well, what you do is you take a prototype, a person who has the classic symptoms, and you put a different name on them, and you give them to randomly a group of medical interns, and then see if it changes their attributions. So we basically made a prototype of a classic case of a patient with this illness, and we said this person has chronic fatigue syndrome. We took the same case definition, and we said this person has myalgic encephalomyelitis. And then what we did was we were able to look at the attributions of, depending on the name, with the same case, did it change attributions of medical interns? And we found it did. So by having proof that a name actually changes attributions, and a more medically sounding name actually does sound more serious. It does sound like it has to be taken more carefully. It isn't something that just has to be put to the side as something that's trivial. To the extent that you can have data that can confirm patient experiences, you have then participated in something that allows us to really make a difference to the patients who are just desperate and wanting to have the information to validate their points of view, and we can provide that data to them.
That's wonderful. And so it sounds to me kind of like it's we have to make a decision whether it's the chicken or the egg, right? Is it the name first, or is it understanding the causes that are going to lead to the name? I mean, it seems quite complex, right?
We need to work on all these different areas.
Exactly.
So for example, is it mono? Mono is caused by the Epstein-Barr virus. Is mono basically something that causes certain people to develop this illness and they don't recover? Well, if you really want to study that, you have to look at a naturalistic longitudinal study over time. And myself and Ben Katz at Lurie Children's Hospital now are recruiting thousands of undergraduates, and we're testing them. We're getting their blood, and then we're getting the self-report data, and then we're following them. 10% of them we expect will develop mono. And then we're going to follow those people and see which ones recover, which ones don't. So we'll be able to have data over time, a naturalistic study, helping us understand healthy people and what happens to those who get sick with mono, and to basically understand, can mono be the possible cause of some people with this illness? So yes, we as psychologists and medical people can work together to not just talk about attributions of names, but we can actually work together to also try to understand the etiology of this illness.
All right, with that, we are going to have to go to our last break. I have Dr. Lenny Jason talking to me on the phone from Chicago, and if you have any questions, we'd love to hear from you. You can text into 786-309-8861. We are talking about chronic fatigue syndrome and the role of community psychology in patient engagement. And you are listening to Radioactive on WVUM 90.5 The Voice. We'll be right back after the short break. Keep it locked.
WVUM.
Best said by Marie Curie, who said that one never notices what has been done, but only what remains to be done.
Coral Gables, Miami. WVUM.
Image is powerful, but also image is superficial. I just totally transformed what you thought of me in 6 seconds.
Coral Gables, WVUM.
Welcome to the new age, to the new age. Radioactive, radioactive.
What's going on, everybody? This is Natalie Kibble, your host on Radioactive. We have Dr. Lenny Jason on air with us, coming in from Chicago at DePaul University, talking to us about his work on chronic fatigue syndrome, the recent name change from the IOM, and it's our role as community psychologists to really try to engage with this work. So if you have any questions for us, please feel free to text into 786-309-8861. And where we're going to go for the last few minutes is kind of what can we do about this? I mean, it seems like it's a very big problem. It seems like there's a lot of work to do. So, Lenny, can you just spend a few minutes telling us what we can do and what's going on out there for people who want to get engaged?
Okay. So, we as community psychologists are often kind of thought of as, well, are we kind of passionate advocates of something? And if we do that, do we lose our objectivity? So in a sense, you often have this issue of, well, you're a scientist, stay on the sidelines, collect data, churn it around, publish it. By the time it comes out, it's 3 years later, and the critical opportunity is gone. Or are we passionate advocates, where we basically get involved, work with community organizations and patients, get data crunched and basically given to people very quickly? So that's a very interesting process. And how do we, in a sense, I do think that we can be objective and we can be passionate advocates. And let me give an example of that right now. The Institute of Medicine just came out with the case definition. They also came out with the name SEID, which I've already talked about, in a sense, is something that, we want to find out how patients feel. Some of the initial information that has come out is that there's a lot of mixed feelings about that name, and we want to find out more concretely. So that is occurring right now, and that's important. But just as important is this case definition. So in a sense, you have a group of scientists who are basically saying, we need to come up with new criteria. Well, the patient groups initially said that they had criteria that they were interested in, which specified certain symptoms that would be required, like it's called the Canadian criteria. And the question is, to come up with new criteria, the first thing they should have done is said, if we're going to come up with a new case definition, let's test it out. So in a sense, when they came up with the Institute of Medicine report and I saw what their new criteria was, I took it, I set up a bunch of decision rules, I took a large data set, and within 2 hours, I was able to have data that could compare their case definition with other ones to sort of see what is it like, what is it not like. Well, the question I have is, why didn't they do it? Okay? And so in a sense, if you're going to come up with something new, you should first compare it with other things. And actually, for Oxford University Press, which I write a blog for, that's going to come out tomorrow, I'm going to talk about that issue. And the reason I write a blog for Oxford University Press is because I wrote a book that came out about 1.5 years ago called Principles of Social Change, where I really talked about what is the role of someone like a community psychologist like me in these types of social change movements. And what we can do is basically collect data, analyze data in a quick and timely way. So when I say a quick and timely way, the day the Institute of Medicine came out with their report, I had data that was really critical for a public policy point of view. And not only that, but I wrote up that paper within a week, and that paper has now been submitted to a journal. That's the type of quick turnaround. If you're interested in being involved in public policy, you have to get the data out quickly. You've got to analyze the data quickly, and you have to have good objective data so that we can, in a sense, be objective scientists and passionate at the same time. We can bring these two together, but the glue that brings them together is working with patient organizations who often can acclimate us, tune us in to what the critical issues are. And with their feedback and their guide, we can get through the thickest forest. We can get through the fog to basically the end of the path, which really involves second-order change. And what is second-order change? Second-order change is really trying to deal with those powerful individuals who set up the status quo that sometimes has to be challenged, as it is in this particular area.
Okay, and so if you're someone who wants to change policy, you're saying that we need to turn this around, we need to get this information out quick. If I'm a patient, or if I'm like just somebody who's listening to the radio right now and I'm very interested, or maybe I know somebody who suffers from chronic fatigue syndrome, what can we do to support the work that you're doing, or support what the patients are trying to do right now? Or is there any way that we can get engaged in this kind of process?
Well, there's a woman named Jen Bria who is putting together an important film. She's an individual who was at Harvard and got sick, and she is putting together a coalition now that's basically trying to find out how people can participate at their own level. And there's actually a Google call that I have with her on Wednesday, where we're going to be talking about how does one do this? How does one put together a citizen organization that basically is able to be focused and directive at bringing about social change? So I'm very excited about what she's doing, but she's only one of several people who's trying to come up with mechanisms and organizations and structures that allow individuals to get involved and participate. So at this time, if I were to say what a person could do, they could call their local support group, whether it's ME or CFS, call it up, find out what they're doing in their local area. If their local area doesn't have one, then look to the state or nationally and basically get involved with people who are trying to bring about change. Get on the bulletin boards, find the ones that reach you, that basically speak to what you believe in, and participate with them. Become an active individual in educating yourself and getting involved. If everybody who has this illness got involved, we would transform basically the playing field that involves right now inadequate resources, inadequate services, inadequate ability to really service the people who have the needs.
Okay, and one of the things that I liked about the email that you initially sent out that caught my eye was that you were blogging about this, and this was getting into mainstream media, right? So when we publish in academic journals, how much is that getting the word out to who it needs to get out, and how do we need to learn from academics such as yourself who are actually using other forms of dissemination of information?
Well, you know, because I've done basic research in this area for many years, newspaper reporters will contact me for my opinions. So when the Institute of Medicine report came out, I had a number of reporters contact me, and I gave my opinions. And one that was in the New York Times seemed to have been well read, but I basically said there were patients who were left out of this process. And by saying just that statement, I had hundreds of people contact me on my Facebook, on my Twitter, on my email, and they basically said, we feel that way. How do we get involved? And one of those individuals asked me to create a poll. And I said, rather than me create it, why don't you create it? And she's now basically put it out there. It's been out for a day. So yeah, there are things we can do to basically work with people in the field to basically help them get their voice out. And yes, whether it's talking to newspaper reporters, or whether it's writing blogs, or whether it's being on this radio program, there's ultimately many ways we can be involved in that. But that's not to say that writing an article for a scientific audience is not just as important. All these things are things that we should be doing. We shouldn't be doing just one thing at the exclusion of the other. This all should be part of our armamentarium as we practice as community psychologists. And what I'm basically advocating is that we are objective. We work with community groups. We work with them over the long term. We use our research for the best possible purposes, and that involves second-order change to confront power abuses.
Wonderful. Well, you almost wrapped it up without me asking you to, but we have about a minute left if there's any kind of core message that you want to leave people with or things that you just want to make sure we don't forget, because we provided a lot of information tonight.
I would say that the ME field is one exemplar of how we as community psychologists can work with patient groups, can also be attached to research communities, and also work with government bodies, all collectively to bring the groups together to basically be a catalyst for change. In this particular area, it is something that can be done, but it can be done in many other areas too. Community psychology is a vehicle for basically bringing about social change. It's really a profession that many people don't know about, and I'm delighted to see what you're doing to get the word out to many others.
Oh, thanks, Lenny. I appreciate it. So this was a fabulous show. I think it was a little different than our normal routine on Radioactive, so I really appreciate you joining us and taking the time on your Sunday evening to call in and share all this wonderful information with us. I think we all know a little bit more about chronic fatigue syndrome now and how to think about our role in creating responsive processes for engaging people and learning more and just getting engaged ourselves. So I'd also like to thank all of you out there for listening in to our conversation tonight on Radioactive again this week. Keep the questions coming. There was a lot of audience engagement tonight, and we always appreciate that. If you would like to continue the conversation, please feel free to drop me an email at radioactive@wvum.org, and I can either answer it or I can pass it along to Lenny. And with that, good night, and keep it locked to WVUM 90.5 The Voice.
WVUM.
We all have world views, whether or not we sort of pay a lot of attention to them. We all have ideas and assumptions behind what we do, and our task is to sort of keep peeling away at the onion.
Coral Gables, Miami. WVUM.
Welcome to the new age, to